Roll call, Madam Secretary.
Thank you, Chair. Member Chernyshenko?
Still trying to figure out the mic. There we go. Present.
Member Fleury?
Ici.
Member Kapoor?
Present.
Member Lakin?
Here.
Member McKenney?
Present.
Membre Pinel?
Ici.
Vice-Présidente Poirier? Chair Kadri?
Here.
Member Kakish? Member Taylor?
Here.
Member Tilley?
Present.
You have quorum, Mr. Chair.
Thank you very much, Ms. Blay. Declaration of pecuniary interest. Seeing none. Confirmation of minutes. The minutes of meeting of April 16, 2018. Are those carried? Carried. Thank you. Communications. There are communication items that have been received and held with the board secretary, and I think Dr. Kapoor or Member Kapoor has a question.
Thank you, Chair. One of the communications we received was regarding post-secondary institutions that have decided to make their entire campus and property 100% smoke-free. Examples are nationwide. Two in Ontario that I know of are McMaster and Western universities. I'm just wondering, through you, Chair, if Dr. Etches or any of our staff can let us know if there's any such work going on in Ottawa that she's aware of, or that we can assist our local post-secondary institutions to get involved with, particularly since the age of initiation of smoking. We've done really well on the kids, and so the age of initiation of smoking has now moved, and most people are smoking in the age of when they'd be in a post-secondary institutions.
Thank you for your question. I am happy to say that when we asked in public consultations for the concept of smoke-free campuses, there was a lot of support, and the conversation is continuing between Ottawa Public Health and the universities and colleges about policy changes that would eventually lead to an outcome like a smoke-free campus, as well as how do we prevent smoking in the first place, how do we support people to quit smoking. There are logistics and complexities that differ from campus to campus, university to university, so that's an active conversation to figure out what will work and how to get there.
Thank you very much, Member Kapoor, for your question. Member Fleury.
Just to, it's an interesting one. I came across recent city agreements relating to motels and hotels where we're not at this point mandating smoke-free environments. And I wonder if you can pursue discussions with the various city providers as those providers would be offering the services on our behalf. So I don't know if you're able to reach into the city to continue those conversations. I'm giving you an example, but I'm sure there's others.
So to clarify, you're talking about motels, hotels that the city pays?
Basically, any contract that the city would have with a provider, in this case, I'm giving you the example of a hotel motel, okay, as they are providing the city the services on behalf of the city, that they be respecting our smoke-free environment regulations.
Certainly, we can look into that. Thank you.
Thank you. Anyone else? If not, can we receive these communication items? Received. Thank you. Motion to introduce reports. Member Kapoor, please.
Thank you, Chair. I move that it be resolved that the Chair of the Board of Health's verbal report, the Medical Officer of Health's verbal report, reconciliation at Ottawa Public Health Update, Mental Health in Ottawa Report 2018, Ottawa Public Health's Vaccinate Ottawa Together Plan, and the 2018 Operating Budget Q1 Board of Health for the City of Ottawa Health Unit Status Report be received and considered.
Is that carried? Carried. Thank you. Okay, moving on to item number 1, Chair of the Board of Health verbal report. We will hold that item. We'll also hold the verbal report from our Medical Officer of Health. Item number 3, reconciliation action at Ottawa Public Health. There's an update and a presentation, so we'll hold that item. Item number 4, Mental Health in Ottawa, Report 2018. And again, there's a presentation on that, so we will hold that item. Item number 5, Ottawa Public Health Vaccinate Ottawa Together Plan. There is no presentation and there are no public delegation for this report. Does anybody have any questions or comments on this item? If not, can we carry it? Carried. Thank you. Item number 6, 2018 operating budget, Q1, Board of Health for the City of Ottawa Health Unit status report. And again, there are no presentations and no public delegations requested to speak this evening. And we do have staff here if anybody has any questions or comments. Seeing none, can we carry that item? Carried. Thank you. And then we'll come back to item number 1, which is my verbal report. Good evening, everyone. Thank you to the representatives for opening our meeting here this evening. It is significant that we are gathered here today at the Wabano Center for Aboriginal Health. For those of you not familiar with the center, it is devoted to providing a wide range of medical clinics, social services and support, and programs for First Nations, Inuit, and Métis people in Ottawa. We appreciate the warm welcome we have received and the excellent tour that board members took before this meeting. And since, as you can tell, I'm a food lover, I want to also thank for the great meal that was provided this evening. For my verbal update this evening, I would like to touch on some developments in local health, news from the province, and community events. Locally, as was mentioned in Ottawa City Council on May 9th, I am pleased to advise that Dr. Vera Etche's appointment as Medical Officer of Health was confirmed by the Minister of Health and Long-Term Care. Vera possesses strong executive leadership skills demonstrated throughout her 12 years in senior public health management. I look forward to continuing our work with her and the entire Ottawa Public Health team in preparing for opportunities ahead and developing the organization's 2019 to 2022 strategic plan. In terms of strategic planning, the Board of Health wrapped up its first strategic planning session for the 2019 to 2022 term earlier this month. The session provided board members with the opportunity to review local community health needs and perspectives to identify potential priorities for the next term. I would like to thank my board colleagues for their participation. And before I go any further into my comments, I do thank and appreciate a round of applause for Vera for her appointment, Dr. Etches. Also last week, I was honored to attend a ceremony for City Manager's Award of Distinction. The City Manager's Award of Distinction recognizes and celebrates the exceptional contribution, dedication, and exemplary service of employees. The award is the highest distinction one can receive through the Employee Recognition Program and rewards. One individual from Ottawa Public Health and one from OPH team won the award. I would like to congratulate the Special Event Advisory Team, SEAT, members from OPH who won in the category of collaboration and relationship building. I would also like to congratulate Kimberly Trotter, who won in the category of diversity and inclusion. Kimberly is here this evening and will be presenting later tonight. Let's give us a round of applause. I also want to recognize individuals and groups from OPH who were nominated for the award, including Andrew Hendricks, Benjamin Lakin, the Ottawa Public Health Contributors to Ottawa Welcomes the World, and the Overdose Prevention and Response Task Force. Congratulations to all of you. Moving to news from the province, I'm pleased to report that we received communications from the Ministry of Health and Long-Term Care in May regarding our funding. The ministry announced a one-time capital grant to support the planning establishments and renovation of the supervised injection services at 179 Clarence Street, and one-time operating funding to support supervised injection services at that location, as well as base funding to support the increasing cost associated with the delivery of the HIV/AIDS programs. In addition, an increase in base funding and additional one-time funding were announced to support the provisions of public health programs and services in the community. Details are outlined in the Q1 budget report before you this evening. Finally, I would like to touch on some OPH work in the community over the past several months. On May 31st, OPH co-hosted 15th Annual Accessibility Day. The day involved remarks from Vera, or Dr. Etches, and presentation on health-related topics offered by OPH. I would like to thank OPH employees for those presentations and for their work in helping to organize the event. They supported the event's theme, A Healthy Body and Mind, and provided participants with valuable information on health and well-being. I would also like to highlight OPH's work to support young people in our community. I recently visited Sacred Heart High School students who were participating in their Grad Inspiration Day at Saunders Farm. At this event, OPH's Promise 2018 campaign was discussed. The campaign encourages a peer-to-peer approach using the hashtag PromIs2018. Youth are encouraged to empower other youth to increase their knowledge on issues related to substance use and sexual health, and to foster a culture of keeping each other safe. Coming back to this evening's agenda, we have several significant reports before us, including OPH's Reconciliation Action Plan. In April, several board members participated in a First Nation, Inuit, and Métis agency tour. I'm especially pleased to see that this report discusses even more opportunities for education, training, and action for board members. I know some board members are already registered for the Ontario Indigenous Cultural Safety Training in July and look forward to more opportunities to take action around reconciliation. And with that, it concludes my report. Any questions or comments on my report? Seeing none, can we receive the report? Yes. Thank you. And moving on to item number 2, Dr. Etches' verbal report. Doctor?
I also want to be acknowledging that we're on Algonquin unceded territory and really honored that Wabano invited us to meet here. Really thank the elders who spoke, the knowledge keeper. The words of wisdom really, I think, helped us start today in a good way. So in my report, I'd like to touch on a few local matters and then an update from our Association of Local Public Health Agencies. So in May, our community partners at the Carlington Community Health Centre received baby-friendly designation, and our partners at the Centertown Community Health Centre received redesignation. And this is a significant achievement. The Baby-Friendly Initiative is a program internationally supported by the World Health Organization. It's to help families be informed about infant feeding and create an environment where barriers to breastfeeding are broken down. It's a lot of work, and so I do want to publicly acknowledge that these community health centers have achieved that status in supporting breastfeeding practices and informed infant feeding in Ottawa. Également, ce printemps, avec l'arrivée des températures plus chaudes, SPO rappelle aux résidents le risque de contracter la maladie du Lyme. Pour aider à prévenir cette maladie, SPO surveille l'évolution des tendances relatives aux tiques et aux maladies humaines, sensibilise les résidents aux risques posés par les tiques et enseigne comment prévenir la maladie. So Ottawa Public Health has been reminding people about Lyme disease and the risk of Lyme disease. To help prevent Lyme disease, we monitor the presence of the bacteria in ticks and human illness trends. We look at the ways we can be educating people, and really to prevent tick bites is the key. So you can prevent tick bites by applying DEET or Caridin, doing a tick check. And this is something, we're living with ticks now. We have to build this into the natural way of checking ourselves, our children, our pets after we've been out. Removing ticks as soon as possible is important to prevent disease as well. So also this month, following on the commitment made at our last Board of Health meeting, the first meeting of the Ottawa Gambling Harm Prevention Network took place. This network includes Ottawa Public Health. We provide a secretariat for the work. I am a co-chair. We're looking for another co-chair. As our first meeting included treatment agencies, Hard Rock Ottawa, and OLG. We made some good progress in identifying actions we can take this year in the short term as well as medium term, and I really look forward to that continued collaboration. Last week, Dr. Kapoor, Doug Kirkpatrick, and I visited, we were participated in the annual general meeting of the Association of Local Public Health Agencies, and there we voted on and considered resolutions relating to a wide variety of topics. There was a resolution about public health funding, sustainable funding for public health, supporting a living wage, food affordability surveillance, the work we do to measure the cost of eating well in Ottawa, for example, infection prevention and control, and Ontario's pregnancy and breastfeeding nutritional allowance. Ottawa Public Health offered an amendment to the Pregnancy and Nutritional Allowance Resolution to have a more equitable approach, and I am pleased to say that that amendment was accepted by the association. So we'll be following the route of those resolutions and the actions afterwards. And that really concludes my verbal update. I'm happy to take any questions. Je peux prendre vos questions.
Any questions or comments for Dr. Etches? No, seeing none. Can we receive her report? Absolutely. Thank you. Moving on to item number 3, which is the reconciliation at Ottawa Public Health update. And Dr. Etches is going to do the presentation. There is one registered public delegation to speak to the report. Oh, sorry, we have 2 now. And what we'll do is after the presentation, we will go to those 2 public delegations. And after they have spoken, we will come back to the board in order for any questions or comments. Okay, so Dr. Etches, the floor is yours.
So merci, thank you, Miigwech, Nakomik, Marcy. I want to thank all the partners who have provided input into how Ottawa Public Health is addressing reconciliation. That would include elders, the Ottawa Aboriginal Coalition, Akausavik, Tungafsingvingat, Inuit, Catalyst Research and Communication. And I want to thank the many public health employees who over the years have been fostering relationships. So people like Penny Burton, and currently the Ottawa Public Health Network of people internally to the organization that are really promoting this work. Today I have with me, so right beside me, Kimberly Trotter, who is currently providing leadership, as well as Dr. Sarah Funnell, who is a First Nations recently successful physician who's specializing in public health, completed her Royal College exams, and they both contributed significantly to this report. The purpose of this report is to seek your approval of our Reconciliation Action Plan, as well as the principles for engagement with Indigenous partners. And I want to start by recognizing that my father was born in Scotland, and my mother was born in Edmonton area to settlers. My parents were actually in Maori territory in New Zealand when I was born, and then we moved to this environment in northern British Columbia on Gitxsan territory. And this mountain, Stegyaden, is what I had the privilege of looking at every day. What I also had the experience of noticing was the difference in privilege that existed between myself and First Nations community members and neighbors. Just based on our origins. Our opportunities were different based on exposure to racism and the history of colonization. Also, I observed the strengths of this community. The Gitxsan were the first First Nations to have oral tradition recognized as evidence in land claims in court. And the art and culture is very strong in the community. So it's important, it's work of Ottawa Public Health, le travail de santé publique est de s'attaquer aux inégalités sanitaires. So it's our work to address inequities in health. And I know that's something the board's considered previously. We have also looked at the Truth and Reconciliation Commission's report, which gives us further guidance about the pathway forward, the principles we can use, which are captured in document 3 of the report before you. Ottawa compte une diversité extraordinaire de personnes inuites, métis et des Premières Nations. And so Ottawa really is in a special position to be able to be a leader in how we move forward in a different way. And this report before you also has the purpose of honoring the strengths and the diversity of First Nations, Inuit, and Métis people in Ottawa. There is a lot of work underway by our partners that we hope comes through in this report. Respect is a principle that the Truth and Reconciliation Commission has spoken to, that our partners are looking for. And to demonstrate respect on the path towards reconciliation, it does begin with acknowledging the truth. And so these concepts of the multi-generational trauma we heard mentioned in opening comments, the effect of colonization that continue, the racism that exists in our existing healthcare service delivery right now, these are things that we acknowledge, as well as the resilience and the self-determination of people in our communities. We, when we talk to our communities, we have heard that the way we need to approach things is to build on a foundation of relationship. La création de relations demande une auto-réflexion et une écoute attentive. So cultural humility and an approach of listening is what we are supporting through Indigenous cultural safety training, through the network within Ottawa Public Health, so that we are reflecting on our own positions of power and privilege, and we're looking to be open to take a stance of continuously learning. And we have heard, one of the things we've learned is that our partners are looking for strength-based solutions, and where there is mutual benefit from our collaboration. This concept of reciprocity specifically is mentioned in the recommendations for your approval, because implementing the reconciliation plan will require continued partnership with our community members, with our First Nations, Inuit, and Métis partners, and at times that may mean we will enter into financial agreements to compensate people for their time. This last slide here, almost last slide, shows some of the work that Ottawa Public Health employees have done in self-reflecting on the experience of residential school survivors and their families. The hearts were written on, there were actions, words you can see stand out like respect, of what Ottawa Public Health employees are planning to do to contribute to reconciliation. Certaines des mesures proposées par le personnel de SPO sont indiquées dans le plan d'action de réconciliation. And this is the way we started to build our plan as well, with input from employees. So you can see in the plan some of the work is already underway. The Indigenous cultural safety training, more than 100 people have been enrolled or completed the training, and will continue that. We also know that we need to evaluate this work, and that the evaluation from the perspective of the community is key. So we'll be listening to our partners, First Nations, Inuit, and Métis in the community, to understand if we're reaching a place of safer service. We also will be facilitating participation in our strategic plan and setting priorities for Ottawa Public Health into the future. So I'm happy to wait until after you hear from the delegations to take questions.
Thank you very much, Dr. Etches. And calling the first delegation, Donna Lyons, Director of Quality Assurance, Education and Training for the Wabeno Center. Welcome, Ms. Lyons, and you have 5 minutes to address the board. Thank you.
Okay, thank you. Yes, thank you for this opportunity and welcome to our beautiful center. My employer, Allison Fisher, is the executive director here, wanted me to do a short presentation in terms of Indigenous cultural safety. So I just have a few slides around Wabeno we can actually go through fairly quickly. We're an urban health center that provides quality, holistically, culturally relevant health services to First Nations and Inuit Métis communities in Ottawa. And we also serve as a center of excellence for urban Aboriginal health. So we do a lot of education and advocacy, so that's kind of where I'm going to be focusing my presentation tonight. So in terms of, oh, just go back, you're going too fast. Thanks. So in terms of the cultural safety training, this is going to be part of your reconciliation plan that you're looking at tonight. So just wanted to highlight and give a little bit more information around that. So like we do know that health service providers, they don't wake up in the morning and determine they're going to be discriminatory to against Indigenous people. It's often unconscious. But it does happen often nevertheless, and we know that it causes harm to Indigenous people. So go ahead. So a lot of the things behind that, those biases or stereotypes, that type of thing, is really based on colonial narratives. So what we hear from Canadians generally, Indigenous people are all assumed to be alcoholics. We're all drug addicts. This gets played out in healthcare quite a bit. We don't know how to parent properly. We're uneducated, we're not intelligent. We're all violent, and if we speak up for ourselves, we're often considered the angry Indian. We all want handouts, supported by the government. We don't care about our health, we're non-compliant. We don't feel pain. And we get special treatments, and we don't pay taxes. Those are the types of things that we hear commonly. Next slide. And there's impacts to those colonial narratives. And those are things that Canadians, like, they may not hear the actual truth. These are things that they hear, and, it gets played out actually in healthcare. So what happens often is, if an Indigenous person goes into a healthcare facility, if they're showing any signs of delirium, if they're confused, they're automatically assumed that they're drunk. So they're told to go sober up first. We experience long waits in emergency rooms. So I don't know if you may have heard of the Brian Sinclair case, who sat in the Winnipeg emergency room for 34 hours and actually died there from a very preventable and treatable illness. CAS involvement. We go into the hospitals to have babies. They're right there to apprehend right off the bat. We're often seen as drug-seeking, so there's often negative and racist comments. Sometimes we're barely tolerated. Our symptoms are ignored. Security could get called. Some people are assumed as they're homeless and just looking for a place to get warm. So as a result, with Indigenous people, they may delay seeking care, or they'll seek care in the later stages of the disease, or not seek care at all. So that's what happens. It's a very common thing. These aren't really one-offs. Very, very common. Happens in all of our hospitals here in the city, and even in across the region. So a little bit about our social determinants of health. You're probably very familiar with this, but what's a little different about the Indigenous social determinants of health, we've added in a slide like intergenerational trauma from the Indian residential schools and other things, the family violence we experience, racism, stereotypes, and our colonial history. Those all impact health. But also culture does too, so culture impacts our health in a very good way. So we use that up very often as part of our healing. So why is equity important to Indigenous people? Because Indigenous health is exemplified by systematic disparities in health outcomes. So we have the worst health outcomes across Canada in all areas. So high rates of diabetes, heart, stroke, arthritis, all kinds of things. And of course, exposure to those determinants of health. As already outlined, we have high levels of poverty, lower levels of education, employment, and so forth. Health system responsiveness comes into play, as mentioned in the previous slides, in terms of racism and discrimination that we often experience. So that really impacts access to health care for Indigenous people. And we also don't see ourselves represented in the health workforce very, very often. When you come to a center like this, yeah, you do see Indigenous people, but in other areas, we don't always see Indigenous people. So you can see on the diagram here, you know, that last picture there with the person way below, that's really where we are in terms of the rest of the Canadian population. So you've probably seen that picture various times, but maybe not without that last piece to it. Next slide. So we just wanted to highlight a little bit more about the cultural safety training. Indigenous-led education is needed on the historical events of Canada and the impact that has had on social and health inequities that we see today. And why is the training important? Well, it can help to eliminate racism, discrimination, and stereotyping within the system. Could change attitudes, behaviors, and correct misinformed beliefs. Like what I mentioned earlier about what Canada hears about Indigenous people. It can influence practice to alter the way decisions are made in terms of resource allocation, service design, service delivery, and informed decision makers such as yourself to influence the way services are planned, funded, and delivered for Indigenous people. It can also positively influence access and health outcomes and address those health inequities. So just shortly, or a quick summary, just want to acknowledge the work that the OPH has done in terms of developing the reconciliation plan, and how you can contribute to reconciliation or reconciliation, address system and individual inequities that continue to exist in society today, and ensure that the OPH staff continue to receive the ICS training. But the one thing I wanted to point out too is that the ICS training is it's a journey of learning. So the online training that you were talking about today is excellent, but it is foundational. So we're working on, we have a training program here within Wabano, so we're working on a model for that training. So that's something that you could probably draw on if you're looking to develop a training plan for your staff. So we're seeing it as more of an ongoing journey. Even as Indigenous people, we learn more. We have Marie Wilson here today, actually. She's one of the TRC commissioners, and just listening to her, I learned so much more. It's just amazing, as we start unpacking a lot of what has happened in the past, then it's kind of the way that we can actually move forward. So I just wanted to end with that note. So miigwech for allowing me to speak and address the board.
Thank you very much, Ms. Lyons. Any questions or comments for the public? Councilor Package, please.
Well, I think there's I can't say there's a lot of progress. Like, we hear the stories every day of what's happening out in the system. So one of the points, for example, I made around, I think it was in the presentation, people don't feel pain. This was just recent in one of the hospitals where an Indigenous woman was given birth, and because she wasn't shown to be showing pain, they assumed that she was on drugs. So then it was one of our physicians here that intervened and prevented the apprehension of that child from CAS. It was just because she just didn't look like she was in pain. So it happens all the time. I think we've got a long way to go to really start making changes in that. We're seeing that leadership is starting to support like a lot of the training and so forth, but it's really when you get down to the staff levels, people who are providing services directly to Indigenous people, intake, reception, all of that has an impact, and everybody should really be trained that are, especially providing direct services to Indigenous people. So it's going to be a while before we can actually measure that impact, because like with the ICS training, we know that it changes awareness and knowledge, so we can evaluate that. But it's going to take us a while to actually get to the point where we can really evaluate the change in services that Indigenous people face. So we're doing a lot of work in that area. So as you go along in your journey, especially with the Reconciliation Plan, we can help in terms of other areas that we're working on, like we're on the same path sort of thing. Mm-hmm. Well, we're just starting to look at that. So right now we have a project underway sharing our stories. So we're actually collecting stories from people, but we're also looking at doing probably a 2 or 3 year project in terms of collecting that baseline data about the experiences Indigenous people have within the health system. So probably a couple of years is going to be spent on developing that survey instrument. Another year collecting the data, so at least we'll have we'll know where we're starting from, and then we have to take a look at how that changes over time. So it's research takes a long time, and it's a pretty intense process. So, but that's something that we are looking at.
Okay, thank you.
Member Taylor.
Thank you very much, Mr. Chair, and thank you for the overview of Wabano. I've had the opportunity to get to know Wabano more and understand the work that it does in our community. I also want to thank the Chair and Dr. Etches in Public Health for having recently arranged an opportunity for Board of Health members to participate in a tour of local Indigenous health and housing service providers. So as much as you think you know, you go on an exercise like that and you realize how little you know. So I find it very productive. My question is really around the Reconciliation Plan itself. So it's been in the public forum for a week, and I'm sure you were in some way part of the consultation process. I'm wondering if you think that it puts us on the right path as a health unit, if you see any risks associated with it, or things that you think it either falls short, or places where you think, and we could go further, or if there are places where you believe we're hitting it out of the park.
Well, I did take a look at it, and I thought it was an excellent plan, and I certainly commend OPH for bringing that forward. And I think it's a good plan in the sense that because of the collaboration and the partnership with all of the Indigenous agencies in this area. So I think a lot of our thoughts and our positions are pretty much indicated in the report. So
Thank you very much. Anyone else? No, seeing none. Thank you very much, Ms. Lyons, for your presentation and the insight on the issue from your perspective and from the Wabanos perspective. Thank you.
Great. Miigwech.
Our next speaker is Connie Saidul, Executive Director of, and Dr. Indu Gambier, Lead Physician for Aquacivic Inuit Family Health Team. Welcome.
Unuku, Kani Oyunga, a Kausivik Inuit Family Health Team Mingaktunga, Amalukta Indu Gambir, Ikanayak. Hi, I'm Connie from the Kausivik Inuit Family Health Team, and this is our acting lead physician, Dr. Indu Gambir. Thank you very much for the opportunity today. Maybe just go back to the... We're going to, we welcome ongoing discussions because obviously we feel that the collaborations with public health are important. We've done a number of successful initiatives with public health over the years. So we do welcome ongoing discussions to sort of evolve what we can do to meaningfully, enhance the patient care that is happening. For today, maybe can we just yeah, it's just on our rotation, so I'll be rotating. Maybe just from the beginning, we can press this slide. For today, we're going to share with you just a little taste of our experiences and our knowledge, so that please feel free to ask questions in between. We have I'm good, thanks. Yeah. So Kausivik Inuit Family Health Team is an Inuit community-based model of primary care, and our mandate is dedicated to the Inuit population. And there are many reasons for this. It's a complex patient population. That's the vision of the that was established by our board of directors. So we are a 100% Inuit community member governed board. We have some very high-level members like Mary Simon, who has international circumpolar experience. We also have some very grassroots community elders, as well as people with both local, regional, national, and international experience. That's our vision statement. So the Kausivik Inuit Family Health Team is established with the vision of improving the well-being of Inuit with the respect and understanding of our community through the provision of a responsive and culturally appropriate model of excellence in primary care. So it's not just that we're culturally appropriate, but we have to be excellent at what we do in order to effectively deliver primary care for our community members. We're going to take you through basically two brief competency building journey messages. I'll do a quick summary, and then Dr. Gambier will discuss some of the initiatives that we have done that have actually been successes with public health, and a few of the patient stories, sort of like case examples to illustrate that. It is important because one of the sort of byproducts of colonialism and the whole race, systemic racism, which isn't as well known, is the desire to lump everybody into one group. So the whole word Indigenous, Aboriginal, Pan-Aboriginal approaches, when really, at minimum, at the national advocacy level, you're looking at First Nations, Inuit, and Métis. And there are real reasons for this. It's not just language and culture, but the health prevalences are also different. And how we go about effectively treating this and delivering care also needs to be tailored specifically. So the first message is that primary care, our experience is that what we do acts as a quarterback or a hub for the patient care. So we're looking at a person as a whole person, not just one disease, right? It's not just TB, it's not just STDs. We're looking at an entire person with all of these health imperatives presenting to us at one time. And for mental health, that's especially so. The only way we're going to be successful in getting anyone to uptake health services is to foster an environment of trust where we can start really prioritizing the health needs and providing continuity of care between not just ourselves, but also between primary and tertiary levels. The second sort of take-home message that we wanted you to be aware of, it's just an example, is that the pain or the expression of pain, both mental and physical, is different. It's different for Inuit, and this is a fact. So, for example, silence does not mean agreement or comprehension. Dr. Gambier will actually tell you a little bit about some of our patient experiences where people present to emerge and are discharged simply because the presentation of pain is different, and we've had to sort of facilitate them actually going back and getting what they need. And it is a matter of life and death in some cases. We do collect patient feedback throughout the year, so that's just an example. We have to be careful about how we do any type of research or any survey question, because it can inadvertently trigger past or present traumatic memories. So that's just an example of someone who has accessed the services. We ask them basically how we help them and what else would they like to see us doing. We do also provide primary care palliative support, so that is some feedback that we receive from that. And it is all about helping both the person who's palliative with the transition and the family as well with their bereavement and the supports that they need. And I'm going to give the microphone to Dr. Gambier now.
I'm going to give you the stories. And the first story is I got involved in it because I work with Doctors Without Borders. And when they needed for H1N1 physician, the academy couldn't find a physician. So my friend said, why don't you do it? And I went there and I said to myself, I don't have to go to Africa. It's third world right here in Canada. So that's how I got started. H1N1, then they were looking for a family health team to start, and I said, okay, I'll help you. But I'm going to take you the stories. We have success stories, we have collaboration stories, and we have stories of how we have earned the respect of the community to come to there. The first story, again, when we were starting the clinic, we said among our physicians that we will not give opioid prescriptions for long term. We'll give the opioid prescriptions for 2 or 3 days. We'll reassess the patient, and then we will give the further. We will manage their pain, but we will not give long-term opioid prescription. I didn't realize the impact of it till because they have N number and their prescriptions are documented. And one of the N number administrator at Health Canada came to our clinic for some other thing, and he says, how come your patients do not have opioid prescriptions? And I said, because we decided we're going to manage the pain but not give opioids. So that's one of the things we made it different. People come there 2-3 days, we see them again, we readjust the medication. So that's what we do. The second thing I want to tell you is our patients had very difficult experience in the healthcare systems. The story is of a lady who went to one of the emergency department and with a pain abdomen was sent home, came back to the clinic. We recognized that she could have ectopic pregnancy, so we did the test. We wanted her to go back to the hospital, and she said she's not going because they don't listen. So I wrote a letter, and we sent her to another hospital, and I told her, if they don't listen to her, she calls us back, and I'll come to the hospital. But with the letter, they did, and she was in operating theater in 2 hours. But what has happened is it brought the trust back for the patients to the clinic. So now they call us before, should we go to the hospital or should we come to the clinic? And many times we'll say, go to the hospital, and we'll call the hospitals. So that's what happens when people start having trust in the healthcare providers, they come with this. So we are their one-stop there. If we will try to send a letter to the emergency department when we send a patient, and call the emergency department so that that patient is seen for the issues it has come and is not blanket taken as a drunk or not having pain or things like that. So that's what we have been able to do that. And I must say, many of the emergency departments are quite responsive now that when we send a letter, they do pay attention. The other story which I want to tell you is our collaboration with OPH. We normalized the urine testing for STD. So now every patient knows that if they walk in the clinic, they have to pee in a bottle. And our reason was we did not want to have a stigma because it's a small community. We didn't want community to think that one has STD and this one. So we made it universal. Everybody pees in a bottle. We test it and decide which one goes to the lab and which one just stays in the. But what we were finding is many are homeless. Many don't have OHIP number, and the labs won't do the testing. So we talked to OPH that we need to do something about it. And the second cause was when they found STDs, treating OPH has it's a given that they have to find contacts. So OPH was very kind, and all the requisitions go under my name to the OPH lab, whether they have N numbers, their OHIP numbers or not, everyone gets, the urine we get tested. Then we had the second hurdle, the problem, but they can't afford the medication. And they won't go to the other clinics to get the medication. So then working with OPH, we did find that we stock the medication, and they would provide us, we will give it. Then we had a third hurdle, contact tracing. We started getting people beaten up at home because they were the contacts. So then we had an agreement with OPH. We would trace the contacts, and if we can't trace it, then we will give it to you. So this system has worked very well over the last 5 years, 6 years. And this is the collaboration we can do. If people listen to us, what our needs are, and we find innovative ways of dealing with it, we can promote the welfare of the community very well. So those are there. The third one is the cancer patients. Contrary to what you hear about the Aboriginal diseases, Inuit have different. Diabetes is said to be the biggest Aboriginal disease. Inuit don't have as much diabetes. We were looked at our records, and we only had 4 or 5 patients with diabetes, although we test every patient for diabetes. And the reason we were scratching our heads, why is it not? The reason is that they are about 30, 40 years behind in change of their diets. So we want education for diabetes for them, collaborate, but that's not the disease we want to focus on. We want to focus on diseases which are prevalent right now. TB is very high in Inuit population. Nasopharyngeal carcinomas are very high in Inuit population. Now, contrary to what everybody says, the antibiotic use shouldn't be as much, but we find they have a lot of strep throat. So if we wait 2-3 days for the strep throat testing coming from the lab, a lot of those kids have ear problems, others. So we have started doing our own testing in our clinic. And then if our physicians are not very well known to spot who's having it, and we start on antibiotic, which is sometimes message different than what mainstream gets. So it's not only the knowledge of cultural, it is of the combining the two knowledges together to good medical knowledge with a good cultural knowledge is going to be the key in getting there, and collaboration about that. We also found that our patients will not go to get consultations at the places because, one, they don't know the city as well. Two, they don't have means to go to the hospitals or the clinics of the specialist. So we want them to come back, the specialists to be in our clinics, so that they come to a familiar place. They know that their primary healthcare provider knows what is the specialist asking, and sometime after seeing the specialist, they go back and see the primary healthcare provider to say, this is what I'm told, should I be doing it? So it's an innovative way of trying to get the appropriate care to the appropriate person. We are also pioneering our mental health program because we find that as intergenerational trauma, there is not a single person in our clinic who has not witnessed suicides, either of their friends or the families or trauma. So what we are focusing right now is a mental health care provided within our facilities. So we bring the specialists there to provide that care. So you have any questions?
Any questions or comments from the board? Councillor Taylor?
Doctor, thank you very much for the presentation, and thank you for the chat during our tour of your FHT. You know, I was moved quite a lot by a lot of the theme of the things you've talked about here tonight, and when we had a chance to chat at the center, were all about communication, about the ways in which we can communicate in culturally appropriate messaging to the Indigenous community so that they know that they have a healthcare provider there that's going to take them seriously. And you've talked a little bit about some of the unique needs of the health challenges of the Indigenous community, maybe as separate from, you know, the rest of the community in Ottawa. Public health does a significant amount of education and messaging on all kinds of subjects all across the board. But one of the things that I don't see kind of broadly in our messaging is messaging aimed at our Indigenous community. Now, maybe it's there and I just don't see it, but I'm wondering what your thoughts are on, I know there's a relational, and you talked a little bit about that, there's a relational mechanism where the community knows you and you know the community, so they'll take messaging from you and from AcuCivic about, you know, the things that they should be concerned about health-wise. But is there something that public health can do more broadly to help inform, you know, the Indigenous community that might be out there but not connected to your clinic about some of the challenges? Is there a method by which we can tailor our communication so it's better received by the Indigenous community?
That's a very big question for me. But I can tell you, when we were doing the TB thing, we had OPH and our clinic together made the posters about the TB, and we posted it. And if those posters are available somewhere else, it will be helpful to other communities. I think it is the basic thing of respect and trust of the information giver. And as the reconciliation plan goes further and OPH takes on that reconciliation role, then they will be respected, that the information coming from them is pertinent to be taken seriously. So to me, going ahead with the plan and then trying to reach the community as trust is the key.
Member Tilley?
So I work at one of the downtown shelters, the Ottawa Mission, and we're talking specifically Inuit population, and certainly we've seen that increase over the last 5 years in this city. With your respect to the primary care clinics, as you know, each of the shelters have those primary care clinics. What is the feedback you're getting from the Inuit population as to, and now we're talking the truly vulnerable, those with severe mental health or addiction issues. Are we meeting the needs specifically to the Inuit population as well as we could, or what other feedback would you have for us, either Connie or Dr. Gambier, as to ways we could better service that population? We also have a hospice as well too, and we're trying to adapt that to the needs of the Inuit population.
We have a nurse and a case manager who goes to the shelters once a week to connect with the Inuit. And we do see many of them coming to our clinic for healthcare. I think meeting their need is, we have never asked that question to them. So I feel that primary health care is the key, because once you know what's, as a whole person you treat it, you don't treat one thing. And many of them don't understand the disease or recommendations. So they're not going to follow many of what has been said in those clinics, because our setup is a little different. We have care providers who speak the language. And many times we physicians, when treat a patient, and if there's a total silence, we will go to the care provider with the case manager with the patient and say, can you check they understood what we said? And many times patients will go to them, and I think that is the issue here. Sometimes silence is taken as consent, that they understand, and once you get to know people, you quickly realize that this silence doesn't mean that they have understood everything. So I think that is what I can say. And Connie may have more.
Yes, I mean, we do work with the shelters because we do regular outreach there. I periodically get a phone call saying, come and get your peeps. Because for whatever reason, right, they're very complex, so it does actually require both of us to be working together to sort of meet the needs. Sometimes we have sometimes we have a different way of communicating, and we can actually track down some of the patient information that isn't readily available otherwise. So we've been doing that, and also working to provide the ongoing care, right? Often what they will receive is some initial episodic care, which is good, at least they're getting something, and then we're looking at the ongoing continuity for that person.
I'm going to tell you a story if you provide me 2 minutes. I was working one evening, and this young lady came to the clinic with a gentleman sitting in there, and she told me that she was hospitalized, was discharged from the hospital, went to the shelter, forgot things in the hospital, went back to get her stuff, and when she went back to the shelter, there was no bed. And then she's crying, sitting on the sidewalk, and this man picked her up. And she was smart enough, she had been to the clinic, and she says, I want to go to the clinic, I don't have my medication. So then case manager came to me and said, she doesn't know the one who has brought her. And I tell you, we were 3 people there, all women, and we have a panic button at the front. And I went to this gentleman, quite a burly gentleman, sitting there in waiting room, and I said, thank you for bringing her, and we will take care of her now. And he wouldn't move. I went back and I asked that girl, how much do you know her? She says, no, I was crying, he picked me up and brought me to the clinic. I went back and I said, he again said, no, I'm going to send, why don't you bring the stuff here, and we would take care of this woman. And I said to myself, I'm hearing so much of murdered and missing women and everything, and what are we doing to prevent it? So my case manager was very scared. I said, don't be, I am just going to go. So finally I went 4 times, and finally he said, okay, I'll bring the stuff. Now it took me 2 hours to find a shelter bed for this girl. We gave her food. We gave her bus tickets to come back to the clinic next morning. We made taxi. We made sure that the taxi takes her to the shelter. And then we called the shelter to let us know that she has arrived. So many things we can do, and it's one thing at a time. But I think if we work collaboratively and understand what is the issues, we can prevent problems from getting bigger. And for me, OPH stands for that, preventing problems in healthcare.
Just by the way, one of my favorite pastimes now, one of our favorite events at the mission is, we just had it last Friday, is the country food feast that we put on for the Inuit population. You may be aware of that.
Yeah.
We arrange with our chef Ricky, hosts that every about once a month, so certainly a treat
They'll
to
bring
see.
all the people.
Thank you. Member Kapoor, please.
Thank you both. And as I was listening to both of your depositions and Ms. Lyons as well, when I think of the acute care system, it's where we well recognize the need for language interpretation. But what I'm hearing is more as much a need for cultural interpretation. And that's something we don't have this is getting a little bit beyond your responsibility, Dr. Etches, but we have a role to play here. And I'm trying to see how we can best make sure that that's available when it's needed. Your team is doing a lot of that work, but it's not always there. And I'm wondering, is there a role for that as a community for us to start working on trying to make sure that that's available, again, as needed in a 24/7 basis for acute care relations, since the acute care model is very much the prevalent culture, based in the prevalent culture. I don't know if we can help put that together, but I'd like to hear if you think that's going down the right path.
I think it's going on the right path, and I must say that the hospitals have recognized it as their need. CHIO especially has recognized it and is working on it because we share a lot of patients with them. We see them and they see them. We do. And the TOH has also recognized. But you know, hospitals are big systems. It takes time for them to move on these things. But definitely it is needed. But I think our letters to the emergency departments written and telling patients, don't move it. If they send you home, call us. So those things are working.
Yeah, I'll just reinforce the idea of the phone conversation and the letter are both invaluable in those situations. Thank you.
Yeah, in terms of, we'd be happy to actually brainstorm and collectively look at something that might actually be able to enhance what we already do. We are starting to identify, as she said, with CHIO, like a dedicated person who will regularly, right, be able to sort of follow the cohort of patients and be on site at the different at the hospital site as well as our own.
Thank you very much. Anyone else? Seeing no other comments, Connie, I want to thank you and Dr. Gambier for your work, not only through this center, but on an ongoing basis with the Indigenous population. And, you know, you described a couple of challenges that you're facing. And listening to the response that you provided, Member Kapoor, just a few minutes ago, it suggests that you know the avenues. You have the avenues. It's now just trying to find somebody to believe in those avenues. So thank you very much for all your work. Thank you. The end of our public delegation, so I'll bring the report back, recommendation back to the board for any questions with our staff and any comments. Any questions for staff? Oh, Member Kapoor, please.
Thank you. Thanks for the report. Thanks for the work that's all gone into it and the connections. In the report, we talk about having an annual report back to the board, and I'm assuming part of that is having specific goals, measures, and so would that be expected, say, Q2 and 19, or is that getting a little ambitious for the first one?
An annual report from now another year is June. I mean, June is a good month to recognize Indigenous people in Canada. There's Aboriginal Awareness Day on the 21st, Indigenous Awareness Day. And so, yes, specifics we're looking to develop, we've mentioned in the plan. In the next steps is an evaluation framework, so you could expect to see that materialize by next June.
Thank you. Anybody else? Just want to turn the floor back to you, Vera, and to your other two partners, Kim and Dr. Fennell. Either one of you have any comments on the report or any suggestions?
No, I can just say it's a real honor to be here tonight, and the conversations have been great. I'm so grateful to the partners for sharing their perspective and for supporting us on this report. It's been a real privilege to work on it.
Dr. Fennell?
Thank you, Mr. Chair. It's fancy microphone. I think the one thing I'd like to share a reflection is that OPH's Reconciliation Plan isn't a reaction to the Truth and Reconciliation Commission. OPH has been working towards reconciliation before the TRC report came out, and I think that speaks volumes to the leadership and to the desire to reduce the health inequities of Indigenous people. So I just wanted to share that with you. Thank you, Mr. Chair.
Thank you very much. Any other comments? Oh.
So I think I'll just conclude reflecting that tonight we had quite a bit of discussion about health care, and you were asking Member Kapoor about whether this was in scope or out of scope, and I think you will recall we are expected to influence healthcare planning and service delivery through our relationship now with the Local Health Integration Network. And so we do see that we have a key role. We've been fostering actually, as a facilitator, supporting hospitals, mental health care providers, community health centers, public health, to come together with our Indigenous health service providers, some of whom you've heard from tonight, to set out those goals for the health system that would promote Indigenous health. So we are working collectively on these things.
Thank you very much for that. And so back to the board. There are 3 recommendations on this report. Recommendation 1, approve the Ottawa Public Health Reconciliation Plan as discussed in this report and detailed in document 1. Number 2, recognize the importance of consistent community and partner engagement and support the concept of reciprocity in work with First Nations, Inuit, and Métis partners and community members. And 3, adopt a formal mechanism to ensure future board members have opportunities to participate in Indigenous cultural safety training and other learning opportunities in support of Reconciliation Plan. Is that report carried? Carried. Thank you very much. Thank you to the presenters. Moving on to item number 4, which is the Mental Health in Ottawa Report 2018. We have Gillian Conley as well as Mr. Lakin, Ben Lakin, to do the presentation. We do have one public delegation after the presentation to give us their thoughts, and then we'll come back to the board for Q&As. Welcome, Gillian and Ben, and the floor is yours.
Thank you. Thank you very much, Chair. I'd like to start off by introducing both Benjamin Lykin and Amira Ali. Both of them were instrumental in getting this report forward. Ben is our supervisor for mental health, and Amira is our senior epidemiologist. Purpose of me presenting here today, I'm just going to be providing some key findings from our report and really outline how this report will be a launching pad to spark discussions with community partners on improving mental health and addiction programs, services, and policies in our community. The report before you is one of the initiatives under our strategic direction, Foster Mental Health in Our Community. It is the first local surveillance report on mental health in Ottawa. It's truly a fulsome report as it examines mental health beyond the individual level. It examines mental health in our societal and community context as it provides local data where possible on the individual, family, community, and societal factors that contribute to mental health outcomes. Very specifically, the report describes the current state of mental health and well-being in Ottawa, residents, including residents living with mental illness and substance use disorders, as well as identifies factors that influence mental health outcomes. Some key findings are outlined on the slide up here. Overall, the report found that many Ottawa residents reported very good or excellent mental health, happiness, and life satisfaction, which was similar to the rest of Ontario. However, over the past 10 years, Ottawa residents have reported lower levels compared to the rest of Ontario of strong community belonging. As well, fewer Ottawa residents reported high psychological well-being compared to the rest of Ontario. The report also highlighted that there are individuals in our community with poor mental health. For instance, the rates of emergency department visits for mental health and addictions increased by almost 45% since 2007, which is primarily driven by an increase among young youth and young adults. In further examining this data, it was found that residents living in less advantaged neighborhoods had more than twice the rates of emergency room visits for mental health and addictions conditions compared to those living in more advantaged neighborhoods. The report also found that self-harm and suicide continue to be of concern. On average, there are now 80 deaths by suicide every year in Ottawa. In addition, recent 2017 data revealed that 1 in 9 youth seriously considered suicide in the past year, with about 60% of those students reporting that they wanted to talk to someone but did not know where to turn. And finally, the report outlined that statistics showed that there were populations in Ottawa that more frequently reported poor mental health outcomes. This included populations from low income with lower education levels, new immigrants, older residents, people who rent, those living alone, and those who are unemployed or unable to work. The team further examined the findings from this report and emerged 4 key themes that have significant impact on Ottawa residents' mental health. These key themes are resilience, family relations, social connectedness, health equity, and stigma. Consequently, a secondary report was developed, which was titled Promoting Mental Health in Ottawa. This report further discusses these emerging themes, and it will be used as a significant launching pad for our community engagement with our partners, as it focuses discussion on how we can be working together to impact mental health of Ottawa residents. And as noted, we will be embarking on a community engagement plan, which includes engaging with community partners, service providers, and individual and groups with lived experience to explore opportunities to work collectively to inform future services, policies, and programs for mental health and substance use in our community.
Hi, everybody. Very excited to share with you something that we started several months ago as part of our community engagement plan, and that was to work with youth directly. In order to work with youth, you have to start working with them from the very beginning and involve them in throughout the planning. And so we're really excited to share with you today some videos that were created. We had over 30 entries from youth across Ottawa, from youth-serving organizations, and from all 4 school boards in the city. And at the end of May, we had the youth come together to, it was hard to judge as there were so many good videos, but the youth actually came together and they selected their 3 favorite videos. So we wanted to show you those today. And first we wanted to show you the 3rd place winner. And we're just making sure we have the videos here. So the 3rd place video is from Catherine Gauthier from École Secondaire Publique ORDRE. And I'm hoping Catherine wouldn't mind standing up and just waving if she's here. Yay, Catherine. And then hopefully the video works. Fingers crossed.
I want to relate to you. I want you to understand that I know what it feels like to have all this pressure and tension surrounding you, having no one to understand how you really feel. Your emotions are valid, no matter what people tell you or the situation you're in. But hiding, numbing your pain with drugs and alcohol, harming yourself physically and mentally is not healthy. You're not a bad person for wanting to hide and escape from this pain. But instead of taking short-term remedies, create a new mindset. Start a new lifestyle so that you can actually enjoy life to its fullest. Just for today, I want you to talk about it. Be honest with yourself. Find out how you really feel. Do something that makes you really happy, like bake a mug cake, because you know what? Life is sweet. Do something for someone else, like open the door and smile. Look in the mirror and tell yourself that today isn't every day. Today's a new start, and today you're going to make it the best day you've ever had.
So that was the third place winning video. The video campaign was called Your Minute, and this was number 2. We're so excited to show you. We almost started it without introducing the second place winner, who is here with us today. Shannon, could you please stand up and wave? Shannon is from St. Pius High School, and this is called A Minute with Mental Illness.
This is my minute. Sometimes it feels like hours, even days, but it's no more than self-doubt prolonging the suffering. Right now it seems unimaginable. Living a life you truly love, you seem to fight new demons every single day and crawl your way into tomorrows with the sole purpose of surviving. But life is so much more than the constant battle. It's about laughing, experiencing new things. It's about waking up in the morning, looking in the mirror and loving what you see. You have an illness. An illness that makes you see the worst in yourself. A disease that makes you too nervous to ask questions in class or too sad to get out of bed. But like a flu, there are treatments. Don't try to fix a broken bone with a Band-Aid. And don't try to fix your mental health with, don't worry, it'll be fine. Your mental health is just as important as your physical health. Don't deprive yourself of what you need. You are important, you matter, you're validated, you deserve it. Treat your mind and body as equal and never be ashamed of who you are. With or without mental illness, you are loved more than you know.
Thank you so much, Shannon. So the tagline for the videos, I was also so excited to show them. I didn't tell you the tagline, which makes a lot more sense now that we've seen them. It's, if you had 1 minute to change someone's life, what would you say? And so all the videos are a minute in length, and it's really a call to action to other youth, which we'll talk about in a second. So the winning video, we've got one of the 3 who put the video together with us today, Adriana Yan. Adriana, would you stand for us? Adriana from the back. Adriana is from Sacred Heart High School, and this video is called Talk About It.
Hey! Hey. Wow, it's been so long since we talked. How have you been?
Should I tell him? I don't really know how he would react.
I guess I've been better some other days.
Just yesterday I went to the doctor. He told me I had some kind of mental illness.
Oh, a mental illness? Really? That's nice. Huh? Did you say something? Oh, wow, I'm sorry to hear that. You know, I'm always here for you if you need any help.
Yeah, thank you. I appreciate it. Anyways, how was your weekend?
It was pretty good. I went camping with the family. It was a fun time. It was very warm outside.
So the videos are going to be used. We're putting the videos together into a package, and working with youth, we're going to put together a facilitator's guide. And this will be a part of our engagement work that we're going to be doing to help spark more dialogue amongst youth. So in school boards, in youth serving agencies across the city, this will be one of the steps we're taking to help create more awareness, reduce stigma. We do know from the report that 60% of youth who were in crisis didn't know where to turn. So this is one of those steps that we're taking so that youth feel more comfortable to talk about it, and that youth are leading the conversation, and we're there to support them. So again, I just want to give another round of applause to all the youth here. Thank you so much.
And in conclusion, just wanted to note that the report had been created in large consultation with an advisory committee, and we'd like to thank everyone who participated, and the list is up on the screen. And so in conclusion to the board, we do encourage you to share this report with residents, community partners, and others, as well as provide us with any recommendations for community groups or partners that should be part of the community engagement plan. Thank you.
Thank you very much for the presentation. And I'm going to call the speaker that's registered. This is Roberto Ortiz and Brent Bauer from Max, Ottawa.
Mr. Chair, just on a point of order, I think we need our 7 p.m. motion.
Thank you very much, Councillor Taylor, for the reminder.
Mr. Chair, on Member Taylor's behalf, I move, be it resolved that the Board of Health approve that the meeting time be extended past 7 p.m. pursuant to subsection 8(1)(c) of the procedural bylaw.
Is that carried? Thank you, Member Taylor, and thank you, Member Kapoor. And moving on to our public delegation, Roberto Ortiz and Brent Bauer from Max, Ottawa.
Thank you, Mr. Chair. Sorry. Here we go. Oh, thank you, Mr. Chair. Members of the board, Dr. Etches and your fabulous staff for inviting us here today as part of this very important presentation on promoting mental health. We would in particular like to acknowledge Councillor McKenney for the catalyst behind this presentation and for her support of Max Ottawa. We would also like to acknowledge our hosts here at Wabano. We are in particular acknowledgement of our two spirited colleagues with whom we are on this particular journey here in Ottawa. We are out of the gate on the cutting edge of your community action plan for promoting mental health, and we're very pleased to be one of the first test cases that OPH is working with in the community to really move this file forward. Max Ottawa is just over a year old, and if we could have the second slide. We have a very short history formally, but our history, in fact, goes back to the Ottawa Gay Men's Wellness Initiative, which was founded in 2002 by a number of community associations, a loose collaboration of organizations, which did great work throughout the past 15 years or so, in particular on sexual health testing, as well as anti-smoking campaigns. Its signature achievement was in 2007 when, with Ottawa Public Health, we established a one night a week on Thursday night gay zone sexual health clinic for gay men, which is a drop-in clinic where gay men can get tested for STIs, but also have related programming supports. It's been a great success for the past decade, and we're very much on board with Ottawa Public Health in terms of expanding that, if possible, over the next decade. We did decide in 2014, a bunch of gay men around town who thought something was missing in terms of a dedicated gay men's health organization. We are, in fact, the first in Ontario to be founded, and only the third in Canada after Montreal and Vancouver. So we're even ahead of Toronto. Yay. We did secure funding support from the Ministry of Health in 2015 after incorporation in 2014, and we launched publicly just over a year ago at City Hall as Max Ottawa, rebranded as Max Ottawa. We've secured funding from both two of the three levels of government. The provincial provides us with core funding, and we've secured federal funding for projects from the Public Health Agency of Canada and Employment and Social Development. We have also started to leverage funding from foundation and private sector supports. So we're on our way to diversifying our funding base. And certainly what we would like to talk to you tonight about is about our emerging partnership with Ottawa Public Health. So I would like to now turn it over to my fabulous Executive Director, Roberto.
Thanks, Brent. Is it working? No? Is it better? No? There you go. Thanks, Brent.
Malgré le progrès, nos communautés font toujours face à des inéquités au Canada, que ce soit en lien avec les services de santé, l'emploi, ainsi que notre sécurité physique et nos réseaux de soutien. Compared to our heterosexual counterparts, we have higher rates of mental health issues. This is due to the stigma not only around our sexual orientation, but for several of us, around our immigration status, gender identity, ethnic or indigenous backgrounds, HIV status, or different physical capacities. Notre vision, mission et objectifs stratégiques reflètent les valeurs de Max. Nous travaillons avec nos communautés et nos partenaires afin d'améliorer l'accès aux services et avoir un impact direct sur le mieux-être des hommes gays, bisexuels, bispirituels, queer et d'autres gars qui aiment les gars, qu'on soit cisgenre ou transgenre, à Ottawa. We have three main areas of activities. Around mental health, we have a navigation service where we offer guys-into-guys intakes and warm referrals to services adapted to their needs. This is complemented by a partnership table where close to 15 partners meet to give direction to our program, but also to address together the gaps in services and training. We are also building on peer strategies to support guys in areas where this approach has proven to work. As for outreach, we are present and visible in the spaces where guys-into-guys meet, to socialize, to hook up, both online and offline. I want to highlight our suburban clinics. We're doing outreach to bring rapid HIV testing as well as mental health navigation for guys-into-guys outside of the city center. In partnership with Somerset West Community Health Center and the local CHCs or CRCs, we go once a month to Canada, Orleans, and Barrhaven. Communities are at the heart of Max. We have a standing community engagement committee to advise our work and to inform us of the emerging trends in our communities. We have also been offering microgrants for community maximizers and the ideas that they want to bring to life. An example of this is Keeping It 100, which is a by and for African, Caribbean, and Black queer and trans support group. This was proposed by community leaders and supported by Max, and after the successful pilot, it is now part of Max permanent programming. Now, in partnership with Capital Rainbow Refuge, we are starting to develop a program that will offer internships at Max for newly arrived queer refugees. This will give them a first employment experience in Canada that is gay positive and safe, and that will enhance their confidence, their working skills, and resumes for future opportunities. Chez Max, nous sommes convaincus que travaillant en partenariat, nous sommes plus forts. Voici un aperçu de nos partenaires à Ottawa, ainsi qu'à travers l'Ontario et le Canada. Nous sommes très fiers parce que malgré que ça fait un peu plus qu'un an de programmation officielle, nous avons réussi à attirer l'attention et le soutien de plusieurs partenaires. For the last year, we have been working with Ottawa Public Health, and we are happy to share that we are committed to working together to improve data collection of our communities, to develop specific mental health services as needed, and a staff member of OPH will be immersed in Max and work with us to ensure the sustainability of our programs. Max is the first, as Brent was saying, the first LGBTQ men's health organization in Ontario and only the third in Canada. We are doing cutting-edge work here. This is a great news story for Ottawa to be proud of. But Max is more than Brent and myself. We are a group of engaged staff, board members, community volunteers, peers, some of which are here with us today. If you can stand up, the Max staff, board, and friends. On behalf of Max, merci à tous et toutes.
Thank you very much, gentlemen. And any questions or comments? Councillor McKenney.
Thank you, Chair. Thanks for coming out tonight. No pun intended. Oh, I know that's like so old, which I am. So old, actually, I was around in 2002 when the Ottawa Gay Men's Wellness Initiative was first established. I actually was a staffer for Councillor Alex Munter, who was the chair of, at that time, was called Health, Recreation and Social Services Committee. And I remember sitting around that table with who was then Medical Officer of Health, Rob Cushman, and talking about the partnership and what we needed to move forward on gay men's wellness. And 2002 was before equal marriage, even before we had the successes that we're seeing today in the rates of HIV and AIDS, and so it was, at the time also quite cutting edge, but so important in the community. And I just want to, I think that you were a bit humble on when you described Gay Zone and the early days in Gay Zone, but where we've come to. And what even the pressures are at the community health center, Centertown, where you meet. If you could just kind of give us a bit of an idea of what the pressures are there, how it started, the successes, how you've had to respond to those successes. Because again, I think it's really important to remember when we're talking about queer men in particular, that we still do see higher rates of depression, suicide, substance abuse. It is, within the community, still something that we have to be so very cognizant about. So, can I just ask you if you could just give us a snapshot of Gay Zone and where it's come from and the successes of that.
So in 2007, Ottawa Public Health realized there were the syphilis rate were increasing. And Nick, jump in whenever you want. So the messaging that was happening then was not getting to our communities, and specific approaches that were needed in our communities. So the group of guys that were already working since 2002 on this messaging for syphilis kept working with other partners like Centertown Community Health Center, the AIDS Committee of Ottawa, Somerset West, Ottawa Public Health, of course, on how to deliver a service where guys would feel welcome and safe, which is what Gay Zone started. Officially in 2007 was established, but opened the doors in 2008. So this year is the 10th anniversary, actually. Invitations coming up for October at City Hall. Because our health, for years, the investment for the health of guys into guys has been coming for HIV. However, we are more than only a virus or bacteria. Our health there's a holistic aspect to our health. We have, our mental health is important, of course, our social health, getting connected to other people. The networks that we have are very different to other straight people because of coming out, because of moving to other places where I'll feel more accepted. Those social networks and family connections are lost or are transformed. So a space like Gay Zone, where there was offered a non-judgmental space to offer not only HIV and STIs testing and vaccination, but also wellness programming like yoga, maybe a book club. There's different programs that have gone through the years, Narcotics Anonymous. This space really is very valued by our communities, but at the time when it was launched, and over the years, this has been full every Thursday. It's one evening a year. We're not advertising anymore because there's a lot more demand than the actual offer that we can deliver at Gay Zone. And the demand comes as well for more than only this programming. So that's where Max came in a few years later.
So I'd like to introduce my board chair, Nick Villela, who in addition to being our volunteer vice chair, also volunteers weekly sorry,
I'm a proud employee of Ottawa Public Health.
He's a proud employee of Ottawa Public Health. So he works one night a week at Gazon. He could fill you in on what happens there.
So I speak just for myself and my experience there. I've been very fortunate to have been employed by Ottawa Public Health for 5 years now, one night a week with the Gay Zone team. And it's a really rewarding experience for me personally to be part of such a committed clinical staff based out of 179 Clarence Street who stay late and take time away from their families to ensure that they can meet the needs of the clients that come to us in great demand every week. Having been there 5 years ago, we certainly don't remember seeing the demand that we're seeing today. Every week, we open our doors at 5 o'clock. Guys show up at 4 o'clock so that they can be in the queue, ready to go, not having to wait. And every week, and I just speak for myself from sitting at the front desk, you know, there is unfortunately me having to have conversations with, well, how can we troubleshoot best if, you know, unfortunately we can't meet the capacity tonight. So as Roberto said, you know, we haven't really been actively promoting necessarily our services because the word of mouth is speaking for themselves. But at the same time, it's troubling having to sit at the counter and say to someone who, you know, probably, you know, made an effort. And some people are driving in from different parts of Ottawa and outside the downtown core and telling someone who drove in an hour that, you know, unfortunately, we just don't have the capacity for you tonight. Certainly not a great experience for me. So needless to say, we still continue to see great volumes of people where we're seeing the majority of people who come to our doors, but there's still every week we're turning people away. But in terms of connection, just even in terms of promotion, we've, you know, seen some really great promotion with our community partners at Gay Zone over the years, and Max has certainly stepped up, as you know, since we've launched last year. As Roberto said, may have mentioned, like there's different groups that are being held in collaboration with the Ottawa Hospital on different subjects that our Community Engagement Committee is advising us as pertinent for our communities. We're working with, you know, updating our social media and online presence with the Gay Zone team, and, you know, we look forward to nurturing that relationship as we go forward.
Overpowering the system.
We have a cap. We have a cap.
That's a good way to keep the chair quiet. Anyways, thank you very much, gentlemen, for your presentations and your comments, and thank you for bringing us the awareness about the challenges that the Max Group faces and yourself in the community. And I do want to thank you, and unless there are any other questions or comments from the board members. Seeing none, once again, thanks very much for presenting. Take care. So now I'm going to turn the report back to the board members, and staff are here to answer any questions or comments that you may have. Just give them a couple of minutes to put the presentation together. Okay, they're ready. Member Tilley, please.
I was somewhat partial to the first video. I don't know if her name's Catherine, but when I hear language like create a new mindset, you know, it's the old getting back to change the narrative. When I hear language like do something for someone else, it's, you know, the first step is get outside of yourself. I'm just wondering, is that the result of the work of Ottawa Public Health getting into the schools and teaching that dialogue and that language?
I think that's a great question, Member Tilley. I think what we've been working with is Ottawa Public Health getting into the schools, but also getting some collective messaging that's being shared, that it's not just public health talking about it, but as well as teachers and administrators, but as well as parents. So it's a collective effort across the community that we're working with all our partners to get that message across. We'd like to take credit for sure. So I'd say yes, definitely.
Please.
Well, thank you very much for the presentations and the report, and congratulations to the team. This is probably the most in-depth report on mental health that I've read ever. And there's been lots of great reports written on mental health. So it walks the line not just between being a really in-depth report, but it's also really relevant. It's not abstract. It talks specifically about our community. I don't have questions on the report. I mean, it presents us with a volume of information, and I know the next steps are now what do we do with the information, and you've laid out what you intend to do with that. One comment I would make pursuant to the chair's comments and Dr. Etch's comments about partnerships, I'm wondering, I didn't see them, or they're not on the list, or if they are somewhere else in the report, I didn't see them, but the Ottawa Police, they report a dramatic escalation in calls with relation to mental health. But under the consultation, it doesn't look like here they were in the consultation process. But if they weren't part of the process up to date, I'd certainly suggest that as we kind of go forward, we look at, working with them a little bit to learn what they're seeing. And I suspect you're about to tell me they were part of the process.
I was going to say they are part of the process, yes, but also, interestingly, one of their staff sergeants reached out to us after having received the report and emailed Ben and I and said, I want to meet with you guys. And so she's one on the top of the list of the people that we're meeting with within the next few weeks to discuss how we can be doing some better synergies, as well as some of the data collection. They're doing some innovative work, and we're looking to see how do we collect that data and continue to tell that story from a mental health aspect. And specifically what she mentioned was that she feels that often police officers are often the first line of defense in a number of mental health crises. And so they're looking at doing an innovative project, I don't know where they're at it, so not to release the additional information, but and they're just looking to see how we can partner with them. So that's one of our top partners that we're looking to reach out and connect with in the next week or two.
Okay, thank you. And I guess tangential to that, I would say, police are probably the biggest ones, but don't dismiss the amount of mental health interactions that our bylaw officers have, our property standards officers have in the city, even our paramedics, the ones particularly doing the community paramedicine program. So I'm sure there's a whole raft of others, OC Transpo, their drivers come into contact with clients all the time that are on somewhere on the scale of having some mental health challenges. So those direct contact city service partners, I would say, make prime candidates for kind of consultation and partnership as you move forward. But congratulations on a stunning report.
I don't know if you heard, but our senior epidemiologist quietly whispered, yes, here. So she's just thankful for
Thank you very much. Member Lakin, please.
Thanks, Chair. Thanks to staff for undertaking this report. It's incredibly informative, and I think if nothing else, it confirms there continues to be some very significant inequalities in health and mental health in Ottawa. Going forward, one of the next steps identified is a consultation process. Can you talk to us a bit about any guiding principles or model that might guide the information or process of consulting? I'm thinking in particular, it became clear in reading the report that there's a clear public health direction on addressing the needs of children and youth, which continue to be clearly identified as a vulnerable population. But I'm getting less clarity around public health direction, for example, around the impact of homelessness, marginalized, economically marginalized folks in the city. So could you speak to what is going to guide the next the consultation going forward?
So it's actually it's a great question. I appreciate it because actually spent a lot of time reflecting on the discussions that have preceded this, and really one of the things that came out loud and clear from both Connie and from Venera was that need for partnership. And what the team is looking to do is actually identify key partners in the community who work with these populations and ask them how best can we be working with them to consult and engage with these populations. So we're not experts in that area, specifically working frontline with some of these populations. So I'll give you a concrete example would be individuals who, so some of the populations that are at higher risk are individuals who live alone, who are low income, and less advantaged neighborhoods. So we're looking to work with some partners in those neighborhoods. So one example could be the Ottawa Community Housing, and seeing if they already have resident groups that exist, and how do we work with that group that already exists. So we're not asking people to come to us, and do some consultation with them and discuss that. Same thing with the homeless population, probably looking at some partners, perhaps someone around the table, to be working with them and seeing what exists already, what mechanisms do they have, groups or network or coalitions with people who have lived experience or people who are individual residents, and working with those to better consult with them to define what are the issues. And so Ben outlined some of the work that we're doing with youth. And so what we found from the report, there's some populations, even through our preceding conversations about the Reconciliation Plan, there's certain populations that we know have lower mental health, and some of them we know why, and some of them we really don't know why. And so looking to pull all those pieces of the puzzle through existing networks and coalitions.
Thank you. I just wanted to perhaps compliment staff. I think we can be really proud of the work to date that OPH has done around engaging children and youth in promoting mental health. And I'm hoping that as we continue to do that, we also move forward in identifying some other vulnerable populations that will benefit from our resources, because I think we're good at making a difference. Let's just not stop here and rest on our laurels.
Thank you for that, and I do appreciate it, and I think that that's actually where we're looking to go within our next direction. So if I was to reflect on our last 8 years in mental health, the first 4 years were about children, and then the last 4 years were really about adults and general population as a whole. And I think where we're seeing from this report, where we're looking to go is what are the inequities, as you initially said, and how do we work with those populations. So it's exactly where we're looking to go. Thank you.
Member Chernyshenko.
Yes, thank you once again. I suppose this is a question I should have asked our presenters and board members from Max Ottawa while they were here with us, but I will also get your perspective. It's probably a short question with a really long answer to it, but given that we hear about the success of their program in the sense of building trust and attracting people even without going and advertising, and yet the overcapacity challenge that faces them, is there anything that you can recommend that we might do to address that? Do you see it purely as a financial issue that perhaps, short of are finding funding from or taking it from elsewhere or getting it from another level? Is that really about funding, or is there something that might be done to increase the capacity of a service, theirs in particular?
Feel free to answer if you're...
I think one piece was some of the work that they're doing that we're contributing to is doing some evaluation and developing best practices from that, and looking to see how we can replicate some of the services that they're doing across the city as a whole. So some of it can be about funding, but some of it's about what we were talking about earlier about cultural competencies and appropriate services. And so some of the stuff that they're doing that's really excellent and cutting edge, how do you share that out with some of the other people in our community that are already integrated into the community and working that way? So our contribution at this point is really doing an evaluation and supporting them in that way to look to develop some best practices, and then that could be shared. That's sort of where where we're looking to go.
Yeah, indeed, and I guess that strikes me on first blush is that taking services out to people that we hear that people are driving in from far away, and then even worse, driving in from far away and not getting to the front of the queue, tells me that one place might to start would be through some sort of satellite program delivered through other health centers or other agencies. So I look forward to knowing more about that in the future. Thanks.
Anyone else? Seeing none, thank you very much to the staff, both Ms. Conley, Ms. Ali, and Mr. Lakin for this project and for this report. I also want to take a special moment and thank the 3 young people that were involved in this project also from day one, and I do appreciate the efforts that each one of you have put into it. And I think the messaging that each one of you provided in that 1-minute short video is a great message for the community, for us to take to the community and educate the rest of the young people in the community, if not all. I do want to thank again the staff for this presentation. I think there's a lot of work done behind the scenes. And I also want to thank other partners that have participated with us. And as Member Taylor mentioned, there may be other partners that we may still want to reach out to and need to reach out to. So thank you for that. And based on that, can we carry this report? Carried. Thank you. Sorry. So that basically is the end of our agenda. There is an item on page 7, information previously distributed. I should have received that at the start. So is that received? Received, thank you. Motion to adopt reports. Member Kapoor.
Chair, move be it resolved that the Chair of Board of Health's verbal report, the Medical Officer of Health's verbal report, reconciliation and Ottawa Public Health update, Mental Health in Ottawa Report 2018, Ottawa Public Health's Vaccinate Ottawa Together Plan, and 2018 Operating Budget Q1, Board of Health for the City of Ottawa Health Unit status reports be received and adopted.
Is that carried? Carried. I know I was speed reading, but that was good. Just before we go on to the next items on the agenda or next closing items, I do want to take this opportunity to, as I said at the start of the meeting, I could feel this was going to be an excellent meeting. And I want to thank, starting with the Wabano Center and its staff for holding us and hosting us this evening. What a great job. So thank you for that. I also want to thank the 3, like I said, the 3 youths earlier, as well as all the presenters that came out this evening to present to our audience and to the board. And I also want to take this opportunity to thank the board members for participating in this evening's discussion. So thanks, everybody. And going to motion to which notices have been given previously. There are none at this time. And motions requiring suspension of the rules of procedure. I don't see any. Thank you. Notice of motion for consideration at subsequent meeting. Are there any? Seeing none. Inquiries and answers. Any inquiries or answers for the next meeting? Questions? None. Confirmation bylaw. Member Kapoor, please.
Chair, move be it resolved that confirmation bylaw number 2018-3, a bylaw of the Board of Health for the City of Ottawa Health Unit, to confirm the proceedings of the Ottawa Board of Health at its meeting of June 18, 2018, be read and passed.
Is that carried? Carried. Our next meeting is on September 17th, so wish everybody a great summer vacation. And is the meeting adjourned? Adjourned. Thank you. Thanks very much, everybody. Good night.